So, calcium and phosphorus physiology, and the text has been taken from the Oxford Handbook of Endocrinology. So, turnover. In order to ensure that bone can undertake its mechanical and metabolic function, it is in the constant state of turnover. Osteoclast derive from the monocytic cells, they resorb the bone. Osteoblast derive from the fibroblast-like cells, make the bone. And osteocytes, buried osteoblasts, sense mechanical strain in the bone. Bone mass during the life. Bone mass is laid down rapidly during the skeletal growth at puberty. Following this, there is a period of stabilization of bone mass in early adult life. After the age of 40, there is a gradual loss of bone in both sexes. This occurs at the rate of approximately 0.5% annually. However, in females, after the menopause, there is a period of rapid bone loss. The accelerated loss is maximum in the first 2 to 5 years after the cessation of ovarian function, and then gradually declines until the previous gradual rate of loss is once again established. The excess bone loss associated with the menopause is of the order of 10% of the skeletal mass. This menopause-associated loss, coupled with higher peak bone mass acquisition in males, largely explain why osteoporosis and associated fractures are more common in female. So the role of calcium, it helps in the skeletal strength, neuromuscular conduction, and the stimulus secretion coupling, uh, like the chromatin cells. In calcium in the circulation, circulating calcium exists in several forms, like the ionized form, which is the biologically active form, complexed to citrate, phosphate, etc., which is also biologically active. And the third form is bound to protein, mainly albumin, and in this form, it is mostly inactive. Bone turnover markers, used in some centers, may be useful in assessing the overall risk of osteoporotic fracture, judging response to treatments for the osteoporosis. And the resorption markers, basically the collagen crosslinks. These are the products of collagen degradation. The small fragments of the ends of the collagen molecule are known as telopeptides, which are NTX and CTX, and the measurement of these in the blood is the preferred biochemical measure of bone resorption. The formation markers. Total alkaline phosphatase is not specific to bone and is also found in liver, intestine, and placenta. It is also insensitive to small changes in the bone turnover and is only of the general use in monitoring the activity of Paget disease. Bone specific alkaline phosphatase is the more specific and reliable measure of bone formation. Osteocalcin is a component of the bone matrix, and the serum levels of osteocalcin reflects osteoblast activity. P1NP is a pro-collagen fragment released from the N1 terminal as type 1 collagen is let down. When measured in serum, it is the most sensitive and specific marker of bone formation. The clinical utility of routine measurements of bone turnover markers is not yet established. Bone imaging. Skeletal radiology is useful for the diagnosis of fracture, diagnosis of specific diagnoses like the Paget disease and osteomalacia, identification of bone dysplasia, and not useful for assessing bone density. Isotope bone scanning. Bone seeking isotopes, particularly 99 labeled bisphosphonates, are concentrated in the areas of localized bone cell activity. Isotope bone scans are useful for identifying localized areas of bone disease, such as fractures, metastasis, or Paget disease. However, Isotope uptake is not selective, and so activity on the skin does not indicate the nature of the underlying bone disease. Hence, subsequent radiology of affected region is needed to establish the diagnosis. Isotope bone scans are particularly useful in Paget disease to establish the extent and the size of skeletal involvement and the underlying disease activity. Bone mass measurements. Bone mass is quoted in terms of the number of standard deviation from an expected mean. The most useful way of expressing this is as T-scores. T-score represent observed bone mass in comparison to a, a sex-matched young healthy population. Z-scores are sometimes quoted and relate to bone density according to the sex and age matched group. A reduction of one standard deviation in bone density will approximately double the risk of the fracture occurrence. WHO has established criteria for the diagnosis of osteoporosis in postmenopausal women. No similar criteria have been set in males, but the same thresholds are generally accepted. For some causes of osteoporosis, particularly glucocorticoid use, a less stringent criteria of T-score less than -1.5 should be used as a bone density determined treatment intervention threshold. So, measurement of the bone density. So, DEXA scan, the sites usually uh, included are the spine, femur, and the whole body, and the distal one half of the forearm. And it measures bone mineral per unit area, and it is expressed as gram per centimeter square. And the reproducibility is less than 1% at spine and less than 2% at femur. And the quantitative computed tomography (QCT) and the site involved are the spine and the forearm, and it measures the true bone mineral density expressed as gram per centimeter cube, and the reproducibility is less than is around 1%. Bone biopsy is occasionally necessary for the diagnosis of the patients with complex metabolic bone disease. This is usually in the context of suspected osteomalacia. Bone biopsy is not indicated for the routine diagnosis of osteoporosis. It should only be undertaken in highly specialist centers with appropriate expertise. Investigation of calcium, phosphate, and magnesium. So, uh, uh, calcium measurement of the calcium does not require patients to be fasted. Blood for the PTH and phosphate level measurements should, however, ideally be collected after an overnight fast. In most clinical situations, direct measurement of ionized calcium concentration is unnecessary. However, it is important to adjust the measured calcium concentration for the prevailing serum albumin concentration. Measurement of plasma phosphate and magnesium are not conventionally adjusted for the plasma protein concentration. Urine excretion of the calcium. Measurement of the 24-hour urine excretion of calcium provides a measure of the risk of renal stone formation or nephrocalcinosis in states of chronic hypercalcemia. In other circumstances, particularly in the assessment of the causes of hypercalcemia, an estimate of the renal handling of calcium is more useful. This is most commonly estimated from the ratio of the renal clearance of calcium to that of creatinine in the fasting state. If all values are in millimole, the ratio is typically greater than uh, 0.02 in hyperparathyroidism, and the values less than zero point 0.1 are suggestive of hypocalciuric hypercalcemia. Exclude other causes of hypocalciuria, including the renal insufficiency, vitamin D deficiency. A 24-hour measurement of phosphate excretion largely reflects dietary, dietary phosphate intake and has a little utility. The calculation of the calcium creatinine excretion ratio and the adjustment of the measured calcium concentration. We can see that urine calcium is divided by the urine creatinine multiply into plasma creatinine uh, and divided by the plasma calcium. If the ratio is less than 0.01 in FHH and it is greater than 0.02 in primary hyperparathyroidism, adjusted calcium, the measured calcium plus zero point zero 0.02 into and we take into account in the albumin um, subtracted from the 40. 25 hydroxy vitamin D. This is the main storage form of vitamin D, and the measurement of total vitamin D is the most clinically useful measure of vitamin D status. Internationally, there remains controversy around a normal or optimal concentration of vitamin D. Levels over 50 nanomole per liter are generally accepted as satisfactory, and levels less than 29 nanomole per liter representing deficiency. True stimulation occurs when the vitamin D leaves are less than 15 nanomole per ml per liter. Low levels of 25-hydroxy vitamin D can result from the variety of causes. It is unlikely that serious intoxication will occur with 25-hydroxy vitamin D concentration of less than 125. 125-hydroxy vitamin D. Although this is the active form of vitamin D, measurement of its concentration is rarely indicated. It is sometimes useful diagnostically in the conditions of extrarenal synthesis of 125-hydroxy vitamin D, such as in sarcoidosis. Calcium regulated hormones, PTH, parathyroid hormone. Careful attention should be paid to local measurements for the collecting blood for the PTH measurement. Since PTH secretion is suppressed by the calcium ingestion, it should be measured in the fasting state. The reference range depends on the precise assay employed, but typical values are 10 to 60 picogram per ml. And the PTH-related peptide, it is possible to measure the level of this oncofetoprotein in the serum, but this is very rarely indicated. Sample collection involves specific requirements. Calcitonin assays are available, but the utility is confined to the diagnosis and monitoring of medullary carcinoma of the thyroid. There is no role for calcitonin measurements in the routine investigation of calcium and bone metabolism.